Today, I will be presenting on chronic fatigue syndrome. Chronic fatigue syndrome, or CFS, is also called myalgic encephalomyelitis, or ME, and it is a complex chronic condition where a person feels persistent, severe fatigue that is not alleviated by rest. It can limit a person's daily activities, and it worsens with physical or mental exertion. Key features of CFS include fatigue, post-exertional malaise, otherwise known as PEM, cognitive impairments such as confusion and slow thinking, hypersensitivity to stimuli like light, noise, odors, extreme temperature, chemicals, and simple conversations, autonomic dysfunction like weakness and tremors, muscle and joint pain, sleep disturbances, and immune system dysfunction such as sore throat and tender lymph nodes. Typical clinical findings include that the symptoms worsen significantly after minimal exertion, otherwise known as that PEM, and it appears 24 hours after overexertion and causes a significant drop in a patient's energy levels. This can cause a person to have a reduced tolerance for sustained roles. Prior research has shown that 48% of patients cannot engage in constructive activity and 87% cannot work after experiencing PEM. CFS has an unknown etiology, but it is linked to viral infections. It is triggered by certain infections due to immune and autonomic nervous system dysregulation. For example, infectious mononucleosis, otherwise known as IM, is caused by the Epstein-Barr virus, and it is a trigger for CFS. One study suggests that the majority of patients with CFS report infectious illnesses before the onset of CFS, with 30% of cases due to infectious mononucleosis caused by EBV. COVID-19 also has links to CFS. Studies indicate that up to 10 to 30% of individuals infected with COVID-19 experience long-term symptoms that are consistent with CFS. Young to middle-aged adults and women are also most affected, and patients with a history of other complex medical conditions, such as fibromyalgia or postural orthostatic tachycardia syndrome, are also at risk. The prevalence of CFS among adult populations is quite considerable across the world. In the US, according to a 2015 Institute of Medicine report, between 836,000 and 2.5 million people have CFS. In Edinburgh, Scotland, the annual incidence of CFS is 270 per 100,000 people, and the prevalence is 740 per 100,000 people. The ratio of women to men who have CFS is 4:1, and it is less common in children than in adults, but it is more common in adolescents than in younger kids. And people who get CFS are diagnosed mostly between 40 to 60 years of age, and it occurs in all ethnic and racial groups. Common pharmacological treatments include non-steroidal anti-inflammatory drugs, which are useful for relieving frequent or severe joint and muscle pain, reduces headache, and reduces fevers and inflammation. But the side effects are gastrointestinal distress and bleeding. Tricyclic antidepressants improve sleep, relieve pain via lowering doses than those used to treat depression. They have an anti-anxiety effect, and they improve locomotor activity. But the side effects are sedation, urinary retention, sexual dysfunction, and weight gain. Selective serotonin reuptake inhibitors are helpful for anxiety and depression and other mood disorders in patients with CFS, as well as chronic neuropathic pain. And there are no specific adverse reactions that have been described in the RCTs. Antiviral drugs produce an improvement in exercise tolerance and a reduction in CFS-related concomitant medication usage, and it is well tolerated in the right dosage. Monoclonal antibodies decrease the activity and number of B cells in order to reduce inflammation, but the side effects are neutropenia and an increase of severe infections. Complementary and alternative medicine include nutritional supplements, which are shown to improve CFS-related physical and mental fatigue in patients with specific nutritional deficiencies. And no specific adverse reactions have been described in the RCTs regarding nutritional supplements. Finally, corticosteroids are associated with an improvement in physical fatigue, but the side effects are adrenal suppression, mood disorders, and weight gain. Non-pharmacological treatment approaches include cognitive behavior therapy, or CBT. CBT is beneficial for CFS patients who develop comorbid mental health conditions such as depression and anxiety, and they are also able to relieve the symptoms of fatigue. CBT can also be effective in treatment for adolescents with CFS. Study outcomes found that adolescents with CFS who received CBT as part of a routine clinical care reported improvement in fatigue severity, physical functioning, and school attendance. CBT works by helping people change their negative thought patterns and behaviors to develop more effective ways of coping. Graded exercise therapy, otherwise known as GET, is a structured treatment involving a gradual increase in physical activity. It is grounded in the idea that deconditioning contributes to CFS symptoms, and patients must follow a customized exercise plan, which grades up via slowly increasing in intensity over time. A study investigating the effectiveness of GET delivered to patients with CFS in a routine clinic found a significant reduction in fatigue and significant improvement in work and social adjustment, as well as physical functioning over the course of the therapy leading up to discharge, which suggests its effectiveness as part of routine treatment. Adaptive pacing therapy, or APT, is designed to alter patients' behavior. It considers the fluctuations in symptom severity and delayed recovery from exercise. Patients will set themselves their own reasonable targets for their daily activity to avoid overexertion. And the emphasis of APT is on setting realistic activity levels to avoid overexerting and letting the body rest. Instead of increasing physical activity, the focus is on adapting to the patient's current limitations to prevent symptom flare-ups. A systematic review of RCT outcomes found that activity pacing is effective in reducing fatigue, psychological distress, and depression, while improving physical function in patients with CFS, particularly when a graded escalation of activities was encouraged. And this suggests that APT helps patients manage their energy levels by balancing activity with rest. There is currently no diagnostic test or validated biomarker that exists for CFS. Therefore, individuals may experience their ailment for years before an official diagnostic confirmation. However, the Centers for Disease Control and Prevention, or the CDC, has set standards to identify CFS. The primary symptoms include clinically evaluated, unexplained, persistent, or relapsing chronic fatigue that is new or has a definite onset, so it has not been lifelong, is not a result of ongoing exertion, it is not substantially alleviated by rest, it lasts for at least 6 months, and a patient may experience substantial reduction in their previous levels of occupational, educational, social, or personal activities. And additional symptoms include experiencing at least 4 of the following symptoms that must occur at the same time: memory or concentration problems, a sore throat, tender lymph nodes, muscle pain, joint pain that does not swell or turn red, headaches that are new in pattern or severity, restless sleep, and PEM that lasts more than 24 hours. Occupational therapy will address the impact of chronic fatigue, PEM, and cognitive dysfunction on occupational performance. OT focuses on maximizing participation in meaningful occupations despite limited or fluctuating endurance levels. Rather than remediating the underlying disease, OT's goal is on adaptation and modification of tasks and the environment to enhance engagement in occupations. In the occupational profile, the OT will assess impaired performance patterns because CFS disrupts habits, roles, routines, and rituals that result in occupational imbalance. And a person may experience inconsistent daily routines due to symptom fluctuation, as well as a work and occupational identity loss. OT will also assess contextual factors, such as the physical environment, things like stairs, the work and home layout, including the bedroom and bathroom accessibility, as well as the social environment. This includes the patient's support system and family expectations to return to normality, as well as cultural environment. And this is particularly values of productivity and independence. OT will also address impairments in body functions, such as higher level cognition, memory and attention, energy, sleep, sensitivity to temperature and pressure, immune system functions, functions and sensations of the cardiovascular and respiratory systems, and this includes physical endurance, aerobic capacity, stamina, and fatigability. OT will also address limitations in performance skills, and this includes motor skills such as enduring without excessive fatigue, process skills such as attending, pacing, and continuing, and social interaction skills such as expressing emotion because fatigue affects emotional regulation. OT will assess the impact of chronic fatigue on ADLs, IADLs, education, work, rest and sleep, and leisure. And the goal is to adapt the environment or task to improve participation in meaningful roles. Individuals with CFS experience dissatisfaction with life because their sense of ability, control, and satisfaction are based on performing valued occupations, fulfilling expectations of roles, and maintaining their routines. Some interventions would include energy conservation techniques and pacing strategies in order to balance that activity and rest, activity modification through task simplification, establishing sustainable routines and prioritization of important activities, and modifying the environment. And this could include alternatives to stairs like escalators and elevators, accessible public resting places, avoiding places with bright lights and loud noises, and having accessible bathrooms. Effective management of CFS requires an interdisciplinary approach due to the condition's multi-system presentation and its impact on daily functioning. The primary care provider serves as a central coordinator of care. They confirm the diagnosis through clinical criteria and eliminating similar conditions with overlapping symptoms. The primary care provider also monitors disease progression and symptom fluctuation, and they can refer to specialists such as the psychologist for patients who may benefit from psychological interventions like CBT or upon failure to treat depression and anxiety at the primary care level. The pharmacist reviews medications for side effects that may exacerbate fatigue. They can help start new medications, stop treatment, and also change the dosage of treatment regimens. It is also important that chronic conditions require complex treatment and it can increase patient noncompliance in taking medication, which can lead to drug interactions, adverse effects, increased treatment costs, and even patient confusion. So the pharmacist can offer solutions to provide education on timing, dosing, and adhering to medication. The physical therapist is also very important. In CFS, physical therapy doesn't focus on endurance training, but rather it takes into account the limitations associated with that PEM. The PT focuses on gentle symptom-limited mobility, preventing physical deconditioning. Recent RCTs have demonstrated that physical therapy reduces fatigue severity and improves physical function, sleep quality, and emotional well-being for patients with CFS. The psychologist also has an important role. The psychologist supports emotional processing and adjustments to a life-altering chronic condition, including loss of roles and changes in identity. The psychologist uses psychological interventions to target depression and anxiety. These are conditions that are commonly co-occurring with CFS. And they can help a patient navigate stigma and external pressures from the social environment to return to normality. They can also address psychosocial barriers to occupational participation, such as fear of activity, frustration with limitations, and external pressures to overexert. The prognosis of CFS is variable. For some patients, improvement in symptoms is more commonly reported than having a full recovery. And risk factors that predict progression of CFS include the severity of symptoms at the time of onset, a standard of early management of the disease, having a mother with CFS, and comorbid diagnosis of fibromyalgia, which is a chronic condition that causes widespread body pain, fatigue, and cognitive difficulties. Death in patients with CFS is often caused by another coexisting illness, with cancer and cardiovascular abnormalities the most common causes of death among this population. Patients with severe illness may express an inability to communicate. They may lie in bed in the dark, take frequent showers, and have the inability to watch TV or listen to music. They have a high risk for depression, anxiety, and decreased motivation or interest in previously favored activities. They may also exhibit a higher risk of suicide. Social and cultural risk factors include having unsupportive interactions, social isolation, and negative attributions, which means the tendency to attribute negative outcomes to internal traits instead of external situations. Other risk factors include chronic pain, and suicidal thoughts may arise from CFS because of its impact on jobs and everyday occupations. This can include role loss, occupational imbalance, reduced self-efficacy, and results in feelings of inadequacy and diminished self-worth. This is our fictional client profile. Sam Lee is a 53-year-old male with a history of chronic fatigue syndrome. Sam began to experience persistent fatigue 1 year ago following COVID-19 illness. His symptoms progressively worsened and included sleep disruption, decreased tolerance for physical activity, difficulty concentrating, and post-exertional malaise. Sam was formally diagnosed with CFS 3 months ago. Sam currently receives care in an outpatient rehab center. Sam is a first-generation immigrant from Taiwan who lives in a 2-story house with his wife. His house has 2 steps leading to the entrance and a staircase leading up to his bedroom. He has 2 bathrooms, one in the first-floor guest room and one next to his bedroom on the second floor. Sam's daughter lives at and attends university an hour away. Sam reports limited engagement with his extended family due to fatigue and reduced endurance. Sam values his role as the family breadwinner and places emphasis on his values of productivity and independence. He expresses frustrations with his current functional deficits, limiting his ability to contribute to his household, and feels a sense of external expectation that he will be back to normal in no time. Sam's prior level of function included complete independence in his activities of daily living and instrumental activities of daily living before his CFS diagnosis. He previously enjoyed walking in the park 5 afternoons a week, cooking dinners, and attending family gatherings. He worked full-time in an information technology office. Currently, Sam requires moderate assistance with basic self-care tasks, including showering, personal hygiene and grooming, toileting and toilet hygiene, and dressing, due to the need for frequent rest breaks before exhaustion. Sam is independent in feeding, eating, and swallowing due to less energy expenditure. Sam requires moderate assistance with functional mobility and sexual activity due to decreased endurance and post-exertional malaise. Moreover, Sam requires moderate assistance during meal prep and cleanup, driving, shopping, and household management, as he needs support with task planning when multiple steps and prolonged activity are demanded. Sam requires moderate assistance with social and emotional health promotion and maintenance, as his fatigability has resulted in isolating from social gatherings. He also requires moderate assistance with physical activity and symptom and condition management due to difficulty pacing activities. Sam requires minimal assistance with establishing effective sleep routines due to non-restorative sleep, as well as minimal assistance to engage in social participation due to sensitivity to loud noises and crowds. In addition, Sam requires moderate assistance in job performance and maintenance, as cognitive fatigue and decreased attention span limit his ability to complete tasks efficiently. Our first occupation is meal preparation. The client would have difficulty cooking a dinner meal because of limited endurance, decreased energy, difficulty pacing the task performance, and ineffective sequencing of multi-step tasks. The client would have difficulty following instructions and standing for a prolonged period of time without triggering post-exertional malaise. The client would also have difficulty completing computer tasks at the office, such as managing emails and scheduling, because of difficulty with sustained attention, slower memory, heeding task deadlines, and enduring without demonstrating fatigue. The client would have difficulty maintaining the focus and sharpness needed to complete prolonged screen-based activities. And finally, for the third occupation of dressing, the client would have difficulty with dressing because of decreased muscle endurance, muscle and joint pain, decreased energy, and difficulty pacing the steps. The client would have difficulty dressing within a reasonable time frame and without frequent rest breaks. The assessment that is chosen for this case is the Fatigue Severity Scale, or FSS. And the FSS measures the extent to which fatigue affects motivation, functional performance in daily occupations and work, social and leisure participation, the ability to sustain activities, and physical functioning. It is administered through 9 statements, each rated on a 7-point Likert scale, with 1 being strongly disagree and 7 being strongly agree. The patient completes the questionnaire on their own, and the administration time is 5 minutes, and no special equipment is needed. The psychometric properties include high internal consistency of 0.88 and good test-retest reliability of 0.84, which indicates stable results over time when the fatigue levels remain unchanged. Each item is scored from 1 through 7, and the scores are summed and divided by 9 to calculate an average total score. The final score will range from 1 to 7, and the interpretation of the scores is based on clinical cutoff values. Less than 4 means minimal fatigue impact. Greater than or equal to 4 is clinically significant fatigue, and greater than and equal to 5 is severe fatigue with functional impairment. As you can see in our example, our client's total average score is a 6.7 out of 7, which interprets as severe fatigue because it is higher than the clinical cutoff, and the functional impact would be significant occupational interference. The client scored an average of 6.7 out of 7 on the FSS, indicating severe fatigue with significant impact on daily functioning. This level of fatigue is consistent with the client's reported difficulty enduring through activities, their frequent need for rest breaks, and exacerbation of fatigue following daily tasks. Based on the results of the FSS, the client demonstrates severe impairment related to fatigue. The fatigue severity hinders the client's ability to complete ADLs in an appropriate time and without needing to take frequent breaks, sustain energy to participate in IADLs, sustain attention to complete job performance, and engage consistently in social participation. Due to that PEM, fatigue contributes to the client's disrupted roles and routines, as you can see. The FSS also aligns with the client's functional presentation, including quickly fatiguing during daily occupations, discontinuous task performance due to frequent rest breaks, reduced occupational engagement in the social domain. And the FSS is most appropriate for this client because fatigue is the primary limiting factor affecting occupational performance in CFS. The assessment is also relatively short, easy to administer, and client-centered. And the results directly inform occupation-based intervention planning regarding energy conservation, pacing, and modifying the tasks or the environment. And the FSS can be re-administered at regular intervals to track changes in fatigue severity over time, measure efficacy of OT interventions, and finally, to provide evidence of functional improvement or decline. Thank you for listening to my presentation on CFS. And here are my references. Thank you.